my name's Katie and I'm here today to do an NG tube insertion. Before I came in the room I checked my doctor's orders. I also gathered my supplies and I washed my hands. I entered the room, I provided privacy, I checked my patient identifiers, and I just kind of introduced myself and explained to the patient that we are inserting an NG tube today, answered any questions that he might have. I put a Chuck's pad here, just in case something happens, and also an emesis basin, just in case. Never can be too safe. Alright, first of all, what I'm going to do is I'm going to, I would have my patient in high Fowler's position. This bed's broken, so we kind of have him propped up on pillows. I'm going to check the nostrils to make sure that there's no polyps, any redness, anything out of the ordinary. They both look good, but I'm going to use the left nostril. So next what I'm going to do is I'm just going to listen to the bowel sounds in all four quadrants for 5 minutes apiece. And then what I'm going to do is I'm going to palpate the stomach and just see if there's any distension, tenderness, anything like that. Alright, and then I'm ready to start my procedure, so I'm going to wash my hands. And I'm going to put on some gloves. And then we are ready to start. So what I'm going to do first is I'm going to measure our tubing here. Well, first I'll put in the reflux valve, anti-reflux valve. And I'm going to measure to see about how long of tubing we're going to insert into the stomach. We're going to measure from the nose to the ear to the xiphoid process. Now this is a mannequin. We're going to put a piece of tape here. This is a mannequin, so we're not going to get it in quite as far as this piece of tape, but this is just an estimate of where it should be. So now I'm going to take this and I'm going to lubricate up to 3 to 4 inches of this. And I'm going to take it and I'm going to put it in the nostril. And if he or she feels any discomfort or anything, I will take a break, but I'm going to insert about 3 to 4 inches. And when he starts gagging, I'm going to have an assistant in here, and I'm going to have her take a glass of water with a straw in it and have her hold it for him, and I want him to drink, 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 and so when he swallows, I'm going to keep inserting swallow, 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 swallow. And then when we get it up to the tape on a normal person, I'm going to take another piece of tape I had ready and put it on the bridge of the nose, and I'm going to secure it, not permanently yet, just because we need to make sure that it's in the correct place before we... Alright, so now that we have that, I'm going to check the placement. So what I'm going to do is I'm going to take a clean syringe and I'm going to drop 10 cc's of air. And what I'm going to do is I'm going to just get rid of this. And I'm going to listen to the left of the xiphoid process. And I'm going to listen for a swoosh. If I don't hear a swoosh, I'm going to draw up 3 to 5 mils of stomach contents. And then I'm going to take the stomach contents and I'm going to put it on a pH sheet strip. And I'm going to test the pH, and the pH is between 0 and 4. Then we know we're in the stomach and we can proceed. So what we're going to do next is we're going to hook them up to the suction. Alright. And if they're having a lot of gagging, we're going to look in the back of the throat to make sure there isn't any extra tubing coiled around there. And we're going to hook this up. And when we hook this up here, we're going to make sure that it is completely secure because we know it's in the right place. I'm going to just tape this around here. Alright. And we're hooked up to the suction. And then what we're going to do is we're going to take and put 10 more cc's of air into the blue port here to get it away from the stomach wall. When we do that, then we can turn on our suction. Oops, wrong way. Then we can turn on our suction, and that is insertion of an NG tube. And then I would take off my gloves, I'll wash my hands. But then I noticed that there is some blockage in his tubing and in the suction. So what I'm going to do is I'm going to shut off the suction. This, and also we would tape this before we left, before we started suctioning, we would tape this to the patient's gown, usually with a, if we tape it around and then clip it with a safety pin, that works best. But there's some blockage in here, so what we're going to do is wash our hands, get clean gloves on, and we're going to disconnect the suction, making sure it's off. And we're going to check the placement just to be certain that we're in the stomach. 10 cc's of air. Oops. Listening. While we do this, left of the xiphoid process. And if we heard the switch, so we know we're in the stomach. So then what we're going to do is we're going to irrigate this. How we're going to do this is I'm going to draw up 30 cc's of water. 30 cc's, and we are going to, in a pumping motion, pump this into the port. So, and with the pumping motion, it should propel whatever's blocking it out of the way. And then we can check once again for placement if we need to. And then once we know we're in the right place, we can hook it back up to the suction and turn the suction back on. And that would be irrigation of an NG tube. Then we would take off our gloves, wash our hands, and put clean gloves on. Then what we're going to do is the doctor ordered the removal of the NG tube. So we're going to come in the room, provide privacy, all of our first initial steps, and then we are going to tell the patient that we actually can remove the NG tube today. So what I'm going to do is that first of all, I'm just going to turn off the suction, and I'm going to assess for vowel sounds once again. 5 minutes in each quadrant. Then once we did that, I'm going to just kind of loosen the tape. Alright. Now, what I have to do is check to make sure it's in the stomach. So once again, I'm going to push 10 mils of air while listening, left of the xiphoid process. If we do not hear the swoosh, we're once again going to aspirate or take up about 3 to 5 mils of stomach contents, and then we would test this on a pH strip again, 0 to 4. If we did that, then what we're going to do is we know that it's in the stomach and we want to remove it. So what we're going to do is draw up 20 mils of water and then another 20 of air. And then holding this upright, we're going to flush this through. And once that's flushed, we're just going to have our patient take a deep breath, and hand over hand, we're going to take it out. And once it's out, we're going to assess and make sure that everything's intact and in place. And when I'm done with this, I would go take off my gloves, wash my hands, document how the patient tolerated the procedure. I would check their I&O to make sure that they were intaking and outputting as much as they should. I would put up the side rails, lower the bed, give my patient their call light, and make sure that they were comfortable, and if they need anything else, I would get them.